Thank you very much, Ajit, for the kind invitation. I would be talking to you about the role of ICG in today's practice. As you would know that you've heard about the fluorescein, and ICG has a specific role which is unfortunately declining because of the ways the treatment regimes are evolving. But even today we do have a role of ICG as far as some of the indications are concerned. I've had some travel grants and honorariums from these companies over the year. So now that you know about which wavelength the fluorescein works in, the ICG basically is where it's absorbed maximally at 805 nanometers and is able to bypass some of the areas which the fluorescein is not able to show you, and it goes deeper and shows you a better choroidal circulation. So if you look at this simultaneous fluorescein on this left side and the right side is ICG, you can make out the kind of circulation which is brought about by the ICG is much deeper. It's a choroidal filling which you see better as compared to the retinal vasculature that you see with the fluorescein. So this is when you do a simultaneous, and most of the times we are in practice using a combined procedure so that we can interpret both the lesions better, because our understanding with fluorescein has been much better over the years as compared to ICG. This is another example of the same, which you see a normal fluorescein angiogram and a normal ICG in these patients. Now, if you look at this is a classic membrane seen very well on the fluorescein, while you'll not see it as well on the ICG. You see these large vessels, choroidal vessels, which you see very well. You see some changes happening here, but it is not as well made out by as you see on the fluorescein. So ICG does not show you classic membranes very well. But if you have dark bloody lesions, subretinal blood, serous collections, that's where the ICG's role is much better defined in terms of these lesions. So if you look at when you start the angiogram, this is fluorescein which is still dark. ICG starts showing you this hot spot which is coming up. In this case is actually partly like a macroaneurysm or a hot spot which you need to interpret. The fluorescein at some point also starts fluorescing and it shows you, but what you see here is much better because the ICG is able to bypass some of the blood which is blocking the view. So in this case, you can go and do direct laser to that area of hyperfluorescence and of course give anti-VEGFs and positioning and clear up the blood. This is another such case with a large collection of blood, which is the OCT like this. On the fluorescein ICG, you see a hot spot coming up much better on the ICG with a larger area, defining that there is some occult lesion in this area. So in this patient, again, we gave positioning with gas and then the blood settled down, and after that, you can see that even on the OCT, you can see a small lesion here corresponding to the area. And after that, we repeated the angiogram, and you can see after the clearing of blood an area which afterwards we could go and laser, because before that the blood was blocking the view, so you could go and treat that additionally with laser, because otherwise all the treatments are based now on anti-VEGF injections, and the role of laser is going down, but you could treat it if it's an extrafoveal lesion in these situations. This is another example of a case where if you look at this area on the ICG, an area which is covered with blood, you start seeing this feeding channel which is opening up as in the early phase, while fluorescein does not show you much at this stage, and in the late phase you will see a nice hot spot which is extrafoveal. So this is where you could, in addition to your anti-VEGF, go and also start lasering these areas so that you'd have to give less anti-VEGF. Your recurrence rate would be much less if you are treating them. Here you see, if you look closely in a case like this, there's a nice feeding channel. Feeder vessel treatment was very much in vogue some time back before the anti-VEGFs came in. Now the role is much less, but you can still see that as compared to fluorescein, you saw the feeding channel here much clearer, and within the first 4 or 5 seconds it disappears in the surrounding choroidal fluorescence. So you have to note the very early phase of these lesions, and you can make out whether there is a feeding channel or not, and then you can go and ablate that area. Polypoidal choroidopathy is where its role is maximum today, and these are cases where fluorescein will not show you much, while the ICG shows you these grape-like clusters which arise and confirm the diagnosis of a polypoidal choroidopathy, which we all know responds very well to laser along with anti-VEGFs if there are extra foveal leaks. If there are foveal leaks, then you probably need to do a PDT along. And if you compare this with what you see on the fluorescein, you would just pass it off as a diffuse AMD based membrane and keep injecting, and the patient might require a lot of injections and might not stabilize at all. These are again typical cases. When you see clinical pictures like these, large blotchy collections, you need to suspect IPCV and put them through ICG. So if you look at this lesion, there's a large PED which you've heard on the fluorescein descriptions, and you see these grape-like clusters coming up on the ICG. So you can go and treat these focally, and you can see how the lesion is clearing up with the treatment of laser along with anti-VEGF in these cases. This is again a typical grape-like cluster seen very well, which we have ablated with laser in this area. You can see it's resolved after we laser. Because unless you know that there is a polypoidal change in which area, you cannot use laser and you are only stuck with anti-VEGF treatment. So there are a lot of such examples where you can go and treat focally defined lesions, which can be possibly done only with the help of ICG. Again, a patient like this with a large collection defining an irregular margin, you do a combined angiography and you see a hot spot coming up, typical of a polyp showing up, which is not seen on the fluorescein. So these are simultaneously injected dyes. What we do is we take the 3 ml of fluorescein liquid, inject it into the powder of 25 milligram of ICG, and we mix it and then inject the same into the patient. Actually, the same 3 ml concentration can be used in 2 patients because the spectralis or the HRA, the resolution is pretty good. You can use it, that combination, for 2 cases and still get a very good resolution to diagnose and treat. So this is fluorescein, this is ICG for the same patient simultaneously, and it tells you where you can go and treat. With spectralis, the advantage is that you can also do fluorescein ICG, but you could also pass OCT scans through any area of interest through these lesions. So once you see a lesion like this, you go and pass it, you see a very nice polyp which is actually manifesting on the scan. So there's another advantage now if you use these cases. This is another case. Other eye had a scarred membrane. This eye had a lesion like this, which has come up, a large blotchy lesion, which is showing up on the angiogram, and you see a small area here. Now, there's not much happening on this whole lesion, but there's just a small area here which looks like a hot spot. But here one needs to be careful in interpreting. I think this movie is not coming up. But you need to be interpreting that this is coming up on the fluorescein and this is coming up on the ICG here. And so this is where the hot spot is, while this is actually, if you look at the color photograph, is actually kind of hypofluorescing as an autofluorescent lesion because it's a dehemoglobinized blood which is corresponding to this lesion. So it's important that we always correlate clinical pictures along, because otherwise if you just look at this angiogram, you might be tempted to think that this is something active and you might want to treat it. But this is a classic case where you see that this dehemoglobinized small lesion looks even appears the same clinically as well in these cases. A quick view of a few other situations where we use combined fluorescein ICGs. This is a VKH patient, and you can see how different the appearances would look up, where you look at the ICG, where you see much more large blotchy lesions as compared to what you see on the fluorescein in these cases over a period of the time. This is fluorescein, which starts to show up this typical stippled appearance of hypofluorescence, while the ICG maintains a large hypofluorescent lesion which is fluorescing in these cases. Again, you could do a simultaneous scan of the OCT and you can see exactly what is lying where. CSR, again, the ICG does not show you much in comparison to the classic leak you might see. But you see many other areas which are involved on the ICG, which the fluorescein does not show you. So a lot of cases show us these changes in the RP and the deeper areas which ICG picks up. Now we don't know what is the significance of these. It tells you that we all know that CSR is a much bigger pathology, of a spread out pathology of the RP and chloride, and is not just based on a small leak. So these things could be used in the future to look at a lot of findings related to the mechanism or the pathogenesis, or maybe we could predict which areas might develop recurrences in the future. So these are a few examples of where we use combined fluorescein and ICG in today's times. Thank you very much. Yeah.